शुरू करो, एक ही पार्टिसिपेंट।
मेरा ख्याल है कितने मिनट हो गए? बस 4 मिनट और
एक पार्टिसिपेंट, वो तो फिर मैं अपने घर में भी रिकॉर्ड करके आपको दे सकता हूँ।
मैं कराता हूँ। बिस्मिल्लाहिर्रहमानिर्रहीम। वल अस्र इन्नल इंसान लफी इल्लल लज़ीना आमनु व अमिलुस सालिहाति व तवासौ बिल हक़्क़ि व तवासौ बिस सब्र। सदक़ल्लाहुल अज़ीम। Ladies and gentlemen, today we have a very renowned epidemiologist, and he is MPH and PhD from Texas, and he is working as a professor at the UAE University, and he has given us his precious time, and I think this is very relevant to our postgraduate, because most of our postgraduate faculty how to select a topic, and that should be useful for our country and in terms of epidemiological research. So without wasting further time, I will request Professor Mahboob, Mahboob Ali Shah, to start his presentation, and he will give presentation in such a way that you can discuss him regarding your topic. Thank you.
Thank you very much, Dr. Iqbal Afridi, for your kind introduction. The purpose of this session was to contribute, helping students to learn more about research. So how we use clinical epidemiology methods to answer research questions. As we have seen that in our country, there are so many unanswered questions. To answer those questions, we need to identify, specify that question, and come up with a sound method so that we could address that question. My expertise is in epidemiological research and epidemiology. I teach epidemiology to my PhD students here in UAE, and medical students and MPH students. So epidemiology is a field which we can apply to a number of settings. For example, when we address a research issue related to nutrition, we call it nutritional epidemiology. But when we are using the same designs to address a health-related problem, we call it clinical epidemiology. So I will briefly introduce you to the concept of epidemiology, and then I will, since you are mostly related to mental health field, so I will give few examples of my studies and then explain how we can define a question related to mental health issues and answer it. So what is epidemiology? Epidemiology is field of medicine, a field of public health, where we assess distribution or burden of disease in population. So if our question is how much, for example, we say how much prevalence of depression in our country or in our province, then this will be one of the important aim of epidemiology. First, assessing how much burden of this problem. So there are many health issues. If we are particularly addressing one issue, for example, we are addressing prevalence of depression. So epidemiological technique will help us to identify prevalence of depression in population. But if we are interested to identify risk factor, we already know how much is the prevalence of depression in our country, but we are more interested why some people have depression. Then we have other epidemiological design. So first, what is the prevalence of a particular condition, then we use cross-sectional design. So cross-sectional study or cross-sectional design, we only use when our research question is related to identify the burden of problem in a population. But if our question is why people are suffering from depression, why people are getting depression, then it leads to, what are the risk factors for depression? What are the risk factors which lead to have depression? So if we have this kind of question, then we have two epidemiological design. One is case control study, and the other is cohort study or prospective cohort study. So case control study, we select cases of depression and just get same similar kind of population. The only difference is that they do not have depression. So in case control design, we select cases. So people with depression and our control will be in the same age, similar people, but they do not have depression. So here we compare why these people have depression compared to their fellow similar people who do not have depression. So then we can identify the risk factor for depression. This is by doing a case control study. But even better design to identify risk factor of a disease. For example, risk factor of depression is cohort or follow-up study. So what we will do, we take, but here we have to take very large populations. For example, in one of our study we are doing in UAE, we selected 10,000 households. So we select 10,000 households and we examine adults aged 18 to 40 years. Now we are following for 10 years, right? So this is a cohort study where, so if we are interested to identify incidence of depression and its risk factor, so we'll first exclude that these people which we are selecting do not have depression. So that is important criteria for a follow-up study or a cohort study, that these people do not have depression. So since we for example, sample size is that until 400 people develop depression. So until we recruit and follow up these otherwise healthy people that do not have depression, we follow over a period of time that we get new cases of 400 people with depression. So it is called follow-up study. The important starting base is that these people, for example, we are targeting age 18 to 40. So age 18 to 40 years, for example, we are doing this study. So we got household list of in Karachi, for example, and then we selected a large number of people who are age 18 to 40. But what we exclude, those who have depression, we will not include in follow-up studies. So those people who do not have depression, so we follow, but at the baseline, we will measure what can be possible risk factor for depression, across the countries. Although we are doing first time this cohort study, but in USA, Canada, other countries, they have done a lot of follow-up studies. So we will review those literature and learn what were the risk factors they found for depression. So we'll get a list of all those risk factors. And then we ask every person in our baseline. For example, we selected 10,000 people, 10,000 adults. So we will ask everyone if they have any of these listed risk factors which can cause depression. Okay, so we will come up with the people who have positive history of these risk factors, but other people do not have these risk factors. And then we follow them over a period of time, who will develop the disease, who will develop the depression. Since it is very time consuming, it is very costly, because every person we have to measure every, for example, every 1 year or every 2 years until these many people get depression. So it is very costly. That is why, for example, in United Arab Emirates, chronic diseases are common, like type 2 diabetes is very prevalent. But there's no cohort study why people in UAE are getting type 2 diabetes. So this first time that we got a large grant with New York University, and then we are following. So we took a sample of like 10,000 adults, and we are following these. We just completed the baseline study and we recruited these people. We will follow the thing. Those people, we will follow those people who have not diabetes, and we will follow over another 10 years to see who will develop diabetes. And then we measure all risk factors for diabetes and other chronic disease. So we will say who got this disease, whether those people got the disease who had family history of diabetes, are those people who had obesity, are they more likely to develop? So this follow-up period is time consuming, but it gives accurate picture of the incidence of disease as well as the risk factor. For example, we already have done a follow-up study. For example, we are interested in depression. We have already done a follow-up study and we know the risk factor. Now what we have to do, we have to intervene. What works to decrease depression? So we want to decrease the prevalence of depression in our community. So we want to do the intervention. So what we will do, that these people, we will get those people who have depression and randomize into intervention and control group. So we come up with literature. If you take these measures, we can actually reduce depression in our population. So in So we randomize intervention and control. In the intervention group, we will take those actions which reduces depression, and the control we will leave just like we will measure, but we will not do any intervention, and then we will follow up. For example, it is a 2-year study, and then we will see after 2 years how much depression we reduce in the intervention group compared to the control group. So this is called a intervention or a clinical trial, right? So these are 4 important epidemiological studies. So I will briefly go over some of the examples which I did, some of the cross. What is the problem in our country in Pakistan? That everybody does this cross-section study, but there is very few studies on, few case control studies, very few or no cohort study. I have established a cohort study in 2007, and I am following a 5,000 population up in the rural Gilgit. So it takes a lot of time. It needs a lot of resources because we have to follow every individual in our cohort. So it is time consuming, but it is one of the best design where we assess the risk factor. So let us go with a cross-section study. So for any study, you have to have a clear research question. If you do not have a question, you do not do study, right? The study starts when you have a question. So for example, my question was, why, in recent years, we have noted increase in incidence of suicide in young people in Gilgit region, in these mountain villages. And I was just wondering why in my region people are committing suicide, because it was totally unknown. Suicide was totally unknown before 1990. So what happened after 1990 that now people are committing suicide? So that was my research question, because although my research concentration is on cardiovascular disease and chronic diseases, but this was my village problem. So that is why I asked a question related to mental health. So my question was why people in these mountain villages are committing suicide. So let me briefly introduce the study population, because once you have a question, you describe the study population, how these people look like, what is their age, their socio-demographic variables. So I'm talking about these valleys, these villages up in the north of Pakistan. So you can see how much less research in our country. Just imagine, in this, the top left village is called a village called Karimabad. In this village, in 1827, a person called Robert Macrison, who was president of Oxford University, and who was a physician and nutritionist, who came up in this village and conducted landmark study in those days. Because at that time, Pakistan was not a country, it was part of British Empire. So Robert Macrison is known as father of nutrition, because he was the first person who linked nutrition with the disease. So that is why he is called father of nutrition. So this Robert Macrison was then made army, made a journal for army who are working in India, Pakistan, Bangladesh. So he learned stories about these valleys, Hunza Valley and these villages. And then he noted that these people have very long life. Everybody was living like 90 years and older. So he was wondering why in UK our people are dying before 65 years. What is happening in this Hunza Valley? People are living. So what he did, he did some very interesting studies here, and he published in British Medical Journal at that time and in Lancet. And he reported that I found these people one of the happiest people, because these were cut off from Pakistan. At that time, there was no road between Pakistan and this area. The road come into 72 or 73 when the China-Pakistan corridor was constructed. Before that, this was totally isolated. So he spent here time and conducted very nice studies. So he took albino rats from UK, 600 albino rats, and brought here. And half of them he gave this village diet, and the other half he gave the UK diet, and noted who develops chronic disease. And then after 9 months of follow-up, those albino rats who were eating the diet of these village people, they did not develop any marker for chronic disease. The other who were using British diet, 60% developed marker for chronic disease like diabetes, hypertension, cholesterol. So it was unknown in these valleys. So then he thought that it is because of their lifestyle where everything was organic. They were walking from early morning till night and very physically active. And that is why he thought it is because of this that they have such a healthy life. So, but after that, there was no study done on chronic disease. So we conducted a number of studies to assess prevalence of depression, prevalence of hypertension, prevalence of type 2 diabetes in these valleys. So one of my study was recently, when I went there and talked to the people and government people and Aga Khan Health Service is doing also some work here, and these people, they said we are more worried about not heart disease, but we are worried about suicide. It was rare why our people are committing suicide, particularly young people. So that was my research question. What is the prevalence of suicide? And then what are the risk factors? Why these people are committing suicide? That was my question. So you have a question to assess why is this problem in a population. You take a sample from the population and then you conduct the study. So I will just briefly explain about this area, that this area, early on, it had very high infant mortality rate. When at that time I was teaching at Aga Khan University in 1990, 89 and 90, Aga Khan University conducted a baseline survey in this population and found that this population high infant mortality rate. It was 158 per thousand live births. And then, they saw that in these valleys, this high infant mortality rate. And then they identified that for this, the reason for high infant mortality rate, that less than 10% people had immunization. So kids will get measles and get pneumonia and will die. The other thing was that a lot of people were getting diarrhea and the parents did not know what to do with diarrhea. Even they were stopping water. So they were not using oral rehydration solution. So then they recruited local community health workers, local people, and started a population-based intervention program. And after like these many years, between 90 to 97, the infant mortality rate decreased from 158 to 29. And this compared with our national figure in Pakistan at that time, but it was 1995. It was 95. So just imagine how with identifying the risk factor and taking action, it reduced the problem in the population. It reduced infant mortality rate. It reduced maternal mortality rate. So that is importance of research, that you ask and I define the problem and then you do the intervention to address those issues. So now very low maternal mortality rate across. You compare any district in Pakistan, this population has one of the lowest infant mortality rate, one of the lowest maternal mortality rate. But these are some of these intervention areas. But if you go to other places like in Diamer and Darel and other places, they have not been this kind of population-based intervention. You will find still high rate of maternal mortality, infant mortality rate in this population, in the other villages. And another important thing was that when the first study, I got a grant from Aga Khan University, and I conducted this first study in 1995. And you look at the literacy level in this rural population. So in 1995, this is the education in females. 72% female were illiterate. Okay. And when I again conducted taking a random sample of 1,000 households in 2007, the illiteracy reduced to 54.2. And then in 2019, again, I went up and again took a random sample of 1,000 households, examined the illiteracy, it reduced to 37. So you can see such a progress in education where illiteracy in female reduced from 72 to 37 in this year. So this is the background of the population. So it is now, when I look at under 30 years, 97% are literate, females. So this is very rapid improvement in short period of time in education level, and rapid improvement in maternal infant mortality in these valleys. So so the question from the people was, why we are getting this high suicide rate? So then I conducted an epidemiological study design. So what I did, why this suicide? So what I did was, can you see its slides or not? My voice is coming. Okay. So here, so what I did, I use a mixed design. Sometimes what you do, you do epidemiological design which are quantitative. For example, cross-sectional study to assess prevalence, case control or cohort study to identify risk factor, to reduce the problem in the population, randomized clinical trials. So these are quantitative studies, right? Epidemiological study. But sometimes you can use qualitative study. Qualitative study is to understand the problem in depth. For example, in my study, I noted that a lot of people had hypertension, but their blood pressure was not controlled. So I did a focus group discussion of 12 people, old people, 12 male, female, 12 young people. In each group, I discussed like for 2 hours in depth what they understand, why their hypertension is not controlled, what are the barriers. So this type of study is called qualitative study. Sometimes you do a cross-sectional study as well as a qualitative study to understand in depth the root cause of the problem, right? So you can choose any design. So what I did was, I used for the denominator to calculate rate of the suicide, I used the 2019-98 census population in these villages, and then I used the growth rate from the current census, and then I got the population for each of these study years, which was between 2000 to 2017. So these years I got the denominator, the census population of these villages, and numerator, all those who committed suicide. So how I got the case of suicide? So I went to police record. So any suicide done from the police record. I went to government record, health record. I went to the Akan health record, and then I went to see to all head of villages to find that I do not miss any individual who committed suicide and we don't have a report. So in this way, I got a complete list of cases of suicide. And then I calculated the suicide mortality rate. So as you can see, what is totally different from the rest of the globe is that here the suicide is more, in the, sorry, so suicide is, you can see that it is a 12.5 in males and 17.8 in female. This is totally different for rest of these countries like China, Canada, USA. So I use the same method as they use to calculate the suicide rate. Unfortunately, this kind of data was not available from Pakistan to compare with Pakistan. So this is kind of study where I assess how much burden of the problem, right? How much burden of problem. So to assess the burden of problem is prevalence of these cases each year. So I got the numerator, any case who committed suicide, that was my numerator, denominator was my census population. And it multiplied by 100,000. That is the way we calculate the suicide rate. So you can see that it is like in Canada, it is in male, it is 17.2. It is higher in female than any of these. No, in USA, it's much higher, 21 in females. You can see the red color shows male, right? In male, everywhere it is high. When you look in any of these countries like China, Canada, USA, it is very low. Like in USA, it is 6 per 100,000. In Canada, 5.8 per 100,000. And in China, 9. And compared to this, we have high 12.5 in females. So it is unlike in any of these countries, our rate is very high in females. And then look at the age, because we asked the age of each suicide who committed. So what we did, we went to every household where there was a person committed suicide. So I had psychologists and physician from AKU, and then I trained them, and then they went to every household where a person committed suicide, and they got detailed information from the family, and they identified best friend of the individual who committed suicide, and then they visited the best friend, but we got very pertinent information from the best friend of the person who committed suicide. So if the suicide was a married girl, or then we went to their home also. Not we only asked from the mother and that mother-in-law and father-in-law, but we went to her own house and got information from their mother and house as well as the best friend. So all possible information we got, so we know what things are leading to the suicide. And when we compared the suicide rate between married and unmarried, then you can see a high proportion of unmarried, people committed suicide, 60% compared to 40%. So a lot of females were committing suicide. And then, you saw the education level in these villages, it is high rate, but where the suicide committed, for example, we asked the education of the mother-in-law and daughter-in-law, where a married woman committed suicide. So we asked the education level of the person who committed suicide and the education level of the father-in-law and mother-in-law. Just imagine, in mother-in-law is in a position of authority. Males usually work in down country, in Karachi, in Rawalpindi, but who is the head of the household? It is mother-in-law. And look at the education of mother-in-law. 95% are illiterate, never been to school. Only few had primary school. And look at the education of the daughter-in-law. 27% secondary level education and other 18% college or university level. So these highly educated girls are working under the command of the mother-in-law. So what is expectation of mother-in-law? The mother-in-law expect these newly come daughter-in-law that they have to make the way she was cooking when she came to the house as daughter-in-law. And she had to wash clothes of everybody in the household. That was the tradition, right? But these people who came from the university, they even know how to cook food, So there is this conflict, it is this change between and the other thing was, interesting thing was the all suicide. If there was 100 suicides, 95% suicide happen in those households where both father and mother were illiterate, and only 5% in educated families. So which means this problem is more severe those where either both mother and house are still illiterate. So that is the issue, So these social factors we have to understand to address the problem, to better understand the problem. And look at those unmarried. So those unmarried who committed suicide, we asked their parents' education level. So again, you can see, on the other hand, literacy is very high in young people, like 97% literate under 30 years. But look at those who committed suicide, that father, which is a color in blue, and mother, which is color in green, very low education rate. 79% illiterate and 66% illiterate. So these, and then their education level, you can see how many are secondary, 1.7. So you can see unmarried kids where they have conflict, those where the parents are illiterate, because there is, this gap between the worldview. These young kids who are getting education, highly educated, and what is expectation of their parents. So there is too much difference between their expectation. Another interesting figure I found was, it was amazing. I could not yet comprehend it, why it is so. It needs further research. That you can see, I look at the suicide spring, how many committed suicide out of those who committed suicide. In spring, in summer, the major bulk of suicide is around this season. But in autumn and winter, very low rate. So why it is so? It raises question. When I was looking international literature, they show a relationship between, heat, increase in heat and suicide. So there are very few studies on this issue. But these few studies show that there is as the heat increases, summer season, there is more suicide than winter. So, but we have to further understand, even those studies have a lot of limitations. So we need further good studies to understand this problem. And when I was wondering, because these are the 4 subdivisions which are far away from each other. Dr. Iqbal may have seen, when we go to Ishkoman, that is totally different area. When we go to Yasin, that is total other mountain, so they are totally different. So I was wondering, is this phenomena is true in each of these subdivisions? You can see it is true in each subdivision. The lot of suicide is happening in spring and summer, very few in winter and autumn. So why it is so? So there is something related to the season and where kids are committing suicide. And then I look for the methods they use to commit suicide. And then you can see that in females, the major one is the river. You know, they jump to the river. So that might be that they are using more lethal thing to commit suicide. So that is why there is more high rate. That can be one explanation. Because, you know, in other places, all countries, they use, you know, pesticide and drugs. So they are discovered and they are treated. Here, once you jump in the river, there is no comeback, right? So maybe that is why it is very high in female. And then other methods, which are very common, the top common problem in this particular is low, like hanging, and then, you know, our poison, using poison is very low, 2.3. So, and so when I talk to different, you know, so we did not get a lot of information from father and mother-in-law. That was not right. If you depend on their information, you are knowing nothing. So when I went to actual of their parents, then we got more information. But the real information came from the best friends of these people who committed suicide. So one of the things was that they had depression and they were under treatment, but they committed suicide. And from where they were getting treatment, I will show at the end. Lot of these, because there was no trained psychiatrist in the whole district, no trained psychiatrist. So where they go? They usually go to the faith healer, you know. So faith healer, they call it, you know, a lot of them are actually my relatives. They call it Khalifa, you know. So they go to Khalifa for treatment. And then how the Khalifa will treat, they will write some, they will say some verses from Quran, or they will write some verses in a page, and that is the treatment, right? Because there is no psychiatrist. So when I was doing first survey, I requested Iqbal Afrini, my friend, to come to these villages and train doctors, because the only doctor they go for treatment is the GP or the primary healthcare center doctor, only doctor. So he very kindly used his very precious time, came on his own expenses to my village and trained every doctor there, free of cost. So he spent 7 days to train all these doctors and then came back. Otherwise, there was no doctor. So they are now well trained by Dr. Iqbal, so they can handle depression very nicely. And then you can see other problem. So one of the major problem is law related issue. So for example, the girl educated, university level education, she like to marry one of the person who she likes. But parents say, how come? You have to marry what we say. We never did love and married in our days. How you do this? You know, this is not Islamic. This is not our culture. And the other thing is that, for example, the boy, even the boy said that I like this girl. They will not. It was one of my own class fellow. He liked one of the girl, and he said that to her parents, you know, I like this girl, please marry. But they refused that you have to marry with our relative. He tried several times, but they did not. And then finally he committed suicide. And the mother was going every day to his grave and weeping all the day that why you committed suicide. But the cause was her own self. You know, she refused to marry with this other girl she did not know, because she wanted to. So these are, you know, you can see social problem. These can be addressed and this problem can be solved. And the other one is mother-in-law issue. You know, so mother-in-law, as you saw, her education is 95% illiterate. The daughter-in-law is college or university level education. So there is so much discard between them. So they are coming from totally different world or expectation. So these young educated people see how people live in America. They can see how people live in Canada. But then when they look at it, then they lose hope. So once you lose hope, your resilience dies down and you commit suicide. As a psychiatrist, you know much better than me, you know. So these are social, and then family discard, and then financial issue. So it is also a problem, but not major problem. Major problem are other social issues. And then older people, lot of them were suffering from chronic diseases and they committed suicide, and then some other lot of other issues. So these were kind of, so this study then helped us to understand some of the root causes, which can be addressed, and then we can prevent this. So, and then I did another study where I asked how many of them have, so here I took a random sample of 1,500 households. So I take BSN pass trained nurses to these 3 districts, and we randomly selected 15 households. In each household, we asked both the male and female if they have suicidal ideation, if they attempted, how they attempted. You can see that here, those who suicidal ideation, the major cause is not jumping in the river. The major cause was hanging. So some of them were discovered, then they were, saved. And the river is very few. So some of them, the other common cause was, pesticide, 18% pesticide. So you can see there is so much difference between who committed and died due to suicide and those who did, who attempted and suicidal ideation, but they did not die. And when I look, and then I also assess the depression in these people. So these were random sample of men and males and females. So the prevalence of depression, I use Beck scale, and in Beck scale, the prevalence of depression, symptoms of depression were 5.3% in males and almost 3 times high in females, 14.7% in females. So this is a cross-section study where we assess the prevalence. So if you have to assess the prevalence, then this is the ideal design. But if you want to assess the cause of suicidal ideation, then this is not good design. For that, you have to either do case control study or a cohort study. That is why, you have to understand how to conduct a case control study, how to conduct a cohort study. And I will be happy to send you information to read about case control study and cohort study. You can contact Dr. Iqbal Afridi and say that Dr. Shah promised us to send material, so we read, understand. So I will be happy to send you PDF files to read, so you can conduct case control study. It will, particularly clinical setting, it is very easy. You have to select cases like 200, 300, you calculate sample size and you assess cases, and then just like same people. The only difference is that they do not have suicidal ideation. So you can select them and you can do case control study. So you can assess the risk factor for those diseases. And when I look across 3 districts, in each district, like in Hunza, Nagar, in Nagar district and Gazer district, each district you can see the disparity by gender. In every district, high proportion of females, almost everywhere, almost 3 times females reported suicidal ideation compared to male. Suicidal ideation is this one. You can again see this disparity. Overall, also 3 times high in females compared to males, and it is true for each district. So this is again a cross-section study. I got list of household in each village, total number of household in each village, and then each village randomly selected household, and then randomly selected 1 male and female, and then asked the question about this using Beck scale. And this is a worrisome problem. Both female and male who had suicidal ideation, I asked, did you discuss it with doctor? So very high proportion did not do, irrespective of whether they are male and female. And why it is so? Because we have an outdated British law, this law was published early years of British rule, that if somebody tries, thinks of committing suicide, it is an offense, put him in jail. So this, lot of civilized Muslim countries have taken out this law. Unfortunately, in our country, this law is still existing. This is no place of this law in any Islamic country. It should be removed. There are actual socio-cultural factors which are leading to depression, suicidal ideation, and you are preventing them from getting treatment. So we all, particularly we physicians, have a major role, particularly psychiatrists, you should, through your association, should outlaw these kinds of laws, which are outdated laws. You are familiar with no tobacco law across the globe. This initiative done by physicians from Canada, the Canadian Physician Society came together. Then no person has right, if you are not smoker, other person has no right to smoke cigarette in front of me and expose me to the cigarette smoking. So they enacted this law in their country, and then the globe followed them. And then it was then in USA and then other countries and even Pakistan. Now they are following the no tobacco law by WHO. This was initiated by physicians. So as physicians, we have a big role, because once we remove the law, we can create this unnecessary hurdle so people can get help. They will not then later commit suicide. Otherwise, without treatment, they will go and commit suicide. Seek help for suicidal by ideation, by gender. You can see, like in male and female, you can see that high proportion did not visit doctor. Why? Because they are afraid. If people will know that we are thinking of suicide, we will be taken to the jail by police, or they will ask for money, because we will be committing an offense according to this outdated law. And those who attempted, did they get the care? So those who tried to kill themselves, if they went to a doctor, this was population-based study, so it shows real, so you visit every household, you get the same result which I got. So that is the importance of taking a random sample, where every person equal probability to be part of your study. So that is called random sampling. So you can see a high proportion of people, those who attempted did not visit a doctor because they are afraid that they will be, criminalized. So this thing we have to remove from our country, this outdated law. So even in gender, we saw that it is same for male and female. They do not take care. And from where those who were, suicidal ideation, where they went to get treatment, if they were not going to doctor and psychiatrist, where their major source of treatment, doctor 27%. If some of them who did visit, it is all those few of them you saw, few of them visited. Of those few of them who visited, who they saw, 40%, a high proportion of them went to a faith healer. We call it Khalifa in local dialect in the term. So they actually went to a faith healer to get treatment for their suicidal ideation. And very few went to and psychiatrists, you can see very few, those who dared to go to get treatment. High proportion of them went nowhere. But those 10% or 15% who went, a lot of them went to the faith healer, and few to go doctor, and few had the opportunity to go to a psychiatrist, maybe in down country, maybe in Karachi or in Islamabad, So this is a challenge, so that is why if I have not done the research, nobody have now known the root cause, So this research is so important that we got information about it and we can take action. So now I'm doing a case control study. I collected data from, age, village maze control, but the power was less because I had only 240 people. So I am doing again a study this between 17 to 2022. So it will be then bigger enough sample to conduct the case control study, because you should have a proper sample size. I can easily publish this study, what I got. 240 is a large number, right? From population base, but I did not, because to do a good quality study, I need bigger sample. So I am waiting, and this year I will complete this case control study, where I will look at those people who committed suicide and compare with their friends in the same age, same village, but they did not commit suicide. So what is the difference? Why these people do not commit suicide? What are these factors? What are the positive factors which were there in those people who do not commit? So we can do this same thing for all children, because these young children, this picture I got when I was doing the survey. So in the street, in the field, I saw little kids from school. So I took their picture, and our young generation are our future, right? So to make a better future, although it is very difficult, but we can overcome. So, when we are addressing health problem, there are four phases. One is primordial. So you take the example of diabetes, for diabetes. One is treatment, right? You treat the diabetic person and you treat it. Other is that due to diabetes, they got a foot, gangrene of foot and you do a surgery. So you rehabilitate. These two, in our focus, all the focus is in these two phases of diabetes. Treat them, rehabilitate them. But there are two more important things. One is primordial prevention. Primordial prevention is that you do a survey in school. A large number of kids are not overweight and obese, so they will not chance of getting diabetes, right? So you get these people who are not overweight, obese, talk to them, talk to their parents and congratulate them. Wow, what you are doing, your child is no overweight, no obesity, no underweight, normal, what you are doing. So the parent will be very encouraged. This is a positive reinforcement, right? And when you say the kid, wow, you have normal weight, you are not stunted, not wasted, not overweight, not obese, he will be very happy. So this is primordial prevention. This is the most important thing to do in our society, because this gives positive energy and people can easily follow. We are not doing any action on them. The second thing is primary prevention. For example, we want to prevent diabetes, so we will educate young kids that if they are overweight, obese, we say that you have to reduce. We talk to the parents, we talk to the teacher that they have to do physical activity. So they reduce the overweight, obesity, they become normal. So green is normal color. So why, when they become normal, they will not get diabetes early when they grow. They will not get heart attack. So this is called primary prevention. So in our country, there is little effort on primary prevention and primordial prevention. Healthcare system means how you treat, how you rehabilitate. So this we have to focus. So that is, important thing. We should not underestimate this. So I very much appreciate your attention this morning. So if you need these slides, I will be very happy to send this information, some of these results to Dr. Afridi. He can share some of the key learning points with you. And if you need to learn more about how to conduct studies, I will be happy to share some PDF copies to Dr. Iqbal Afridi. He can share with you. You can contact Dr. Iqbal Afridi. He can share with you. So thank you very much for listening. I really, it was my pleasure. Thank you very much, Dr. Iqbal, for providing me the opportunity to talk to our colleagues.
Thank you very much, Professor Mahboob. Now, I think this is a great opportunity. I was wondering, as the Dean of the College of Physician and Surgeon, that people have their dissertation, select their topic, just prevalence, study prevalence, that is also in the hospital base. So I would like to request you to identify or tell us about the two areas of study where preventive psychiatry can be applied in term of epidemiological research areas, so that people can opt for that, and that topic is useful for our country. I mean, the public mental health topics. What could be the public mental health topic which are burning issue in our country? So, Dr. Mahboob, can you identify a few areas where they should go for research?
Yes, whenever I do a study, it raises so many questions. For example, I conducted a study in 95 and then 2000. So I will share one example. I was talking, I am looking at trends in prevalence of depression in 1995, 2007, and 2019. In each year, I noted that there was more hypertension when the females above 48 years. It is 2 to 3 times higher prevalence than their male counterpart. So I was wondering why it is so. Maybe it is also due to stress. that maybe females have more stress than males and they're getting hypertension? This is a very important question. So here you can do a case control study, So you select the cross-section study you are doing from health center, it represents nothing. It is useless. Because you are not knowing population prevalence, population prevalence, you take random sample of household and then conduct the study. If it is school population, and if 90% of the population are school going, then you can do in school. You don't need to go to houses. Like in my villages, almost 97% under 30 years are going to school. So 3% not coming, it is huge, not huge challenge. So I can get a sample from school and conduct a study in school. Otherwise, I have to get household sample to assess prevalence. It is when you do prevalence in a healthcare setting, it is not, it is just how many coming to your hospital. It is not real prevalence. Real prevalence in the population. Okay, so but in healthcare center, you can do very nice case control study. So for example, you select cases of hypertensive female between 48 and 60 years and select on the same age females who do not have hypertension, and then see the exposure of depression. For example, if you are saying that it is due to depression that this high hypertension, then you can do a case control study and measure and see the association. So case controls is very doable. So in your thesis, ideally, thesis is your foundation for your future research. Your institution only grows when you do good quality research. Aga Khan University is not famous because they are providing good care. It is because the people they are publishing in Lancet, like Bhutta, Dr. Professor Bhutta, who published like 200 papers in Lancet, right? So it is famous because of Dr. Bhutta and because of these kinds of people who do research, who create new knowledge, So, but create new quality knowledge so you can publish your paper in good journals, with impact factor journals, right? So to do, you have to do some innovative question and do some innovative studies. Like we are lacking case control studies, so we don't know what are the risk factors for that condition. For example, what is the risk factor for depression in young people? So to do that, either you have to do a case control study, a cohort. Cohort will be difficult to find resources in a poor country like ours. Maybe you do a case control study. So you can easily find 400 people with depression, 400 people of the same age, same ethnicity, maybe in Karachi, same age, same gender, but they do not have depression. So you compare, so you get list of all other factors and ask each of these person, what are the factors which are causing depression in these people? So you can design these kinds of good studies. You will be able to publish in good high impact journal, and you will help your country, because somebody can take action on those risk factors, because we don't know, a lot of questions are unanswered in our country. So if we ask this kind of right question and use right design and do right studies, once you do a good study, it is your foundation. You can then grow and then you will become our next Professor Bhutta in mental health, right? So it is possible, but you have to learn this technique, how to do good studies. And then you can, in thesis, it's your real opportunity to know these things and do a good study, which will be very helpful for you. Thank you.
Thank you very much. Let me see, is there any question in the chat box? No, there is no question. So let me thank you very much for your kind and very thought-provoking and useful talk regarding the epidemiological basis of research, and you have given example with practical example related to our country, our culture. So I hope people will be able to select topic which are useful for the country and community.
So thank you very much, Dr. Iqbal. Anytime you need, I will come from you.
Thank you very much. Recording कर दो. Recording हो जाए. यहाँ से मैं end करूँगा. वो recording उधर लगाइए. And all वो वीडियो वहाँ से रिकॉर्ड करो.